So good evening to all of you. Today I am back with the fourth lecture in this series. And today I thought for a change, instead of obstetric topic, let me talk on hyperprolactinemia. And all of you know that this is a very important practical issue, especially in infertility. It can be a short note, right, on hyperprolactinemia. Can be a short note of 7 marks or even a 10 marks question. So I thought this would be a small good capsule for you, and you will be benefited by this. Hyperprolactinemia is a very common condition that we come across, especially among infertile patients and women with irregular cycles and galactorrhea. Let us look into this in detail. Hyperprolactinemia, I'll be talking on following headings: definition and etiology, clinical presentation, diagnosis, evaluation, and management. Let's first look at the different definitions and etiology. Hyperprolactinemia can occur in men also, not just in women. So in men and postmenopausal women, we call it hyperprolactinemia when the prolactin is more than 15 to 20 nanograms per ml or 15 to 20 microgram per liter, wherever it is estimated or reported that way. In premenopausal women, if it is more than 30 nanograms per ml, it's called hyperprolactinemia. As far as etiology, there's wide variety of conditions that can give rise to hyperprolactinemia, including physiological conditions such as exercise. So if we estimate soon after the exercise, it will be obviously high. Coitus, pregnancy. So we have to be careful in interpreting hyperprolactinemia during pregnancy. Sleep. That's exactly why we don't want to estimate prolactin soon after they get up in the early morning period. I will talk more about it a little later. Stress due to any reason. Food. It's important to take history, whether they had high protein diet the previous night or just before estimating prolactin. So these are physiological conditions. Pathologically, if we come from above, hypothalamic pituitary stalk conditions such as granulomas, infiltrations, irradiation, Rathke's cyst, craniopharyngiomas, and suprasellar surgery. Then comes pituitary conditions, and they are the main ones: acromegaly, micro or macro adenomas or prolactinomas, paracellular masses. It need not be exactly microadenomas, even paracellular masses, surgery in that region, trauma can also give rise to hyperprolactinemia. More things, not just pituitary and hypothalamic conditions, even systemic disorders such as neurogenic chest. Even if there is trauma for the chest, then there can be hyperprolactinemia. Renal failure. This may be because of the lack of clearance of prolactin. Cirrhosis of liver, cranial radiation, epilepsy, and PCOS. We all know in PCOS, one of the causes of anovulation is hyperprolactinemia, in addition to the other problems. Pseudocysis. Usually in this condition, there will be amenorrhea, and it is misinterpreted by the woman as she may be pregnant. For all you know, it may be hyperprolactinemia causing that. Drugs are very important cause of hyperprolactinemia, and we must take this history carefully. And sometimes stopping the drug itself is the treatment. I will talk again more about it later. Anesthetics. Anyway, these are temporary ones. Anticonvulsants. When the patient is on long-term anticonvulsants, then we have to be cautious. Antidepressants, antihistamines, antihypertensives. Most of the women will be on long-term antihypertensives, and if you estimate prolactin in them, you have to be careful in interpreting. Cholinergic agonists, dopamine receptor blockers, and dopamine synthesis inhibitors. Not just them, there are more drugs. Oral contraceptive pills, antipsychotics. Of course, it's a debate whether to stop antipsychotics or whether to deal with or stay with hyperprolactinemia caused amenorrhea. Neuroleptics, catecholamine depletors, and opiates, and opiate antagonists as well. And finally, neuropeptides. So anything and everything can cause hyperprolactinemia, and we have to be very careful in interpreting them. So that's why the knowledge of the etiology is very important. Otherwise, you may unnecessarily treat, or you don't know how to treat. What is the clinical presentation? Clinical manifestations of hyperprolactinemia are relatively few. That's the problem. By the time you diagnose, it may be too late because patients do not have many symptoms. Usually, they are easy to recognize. They cause typical symptoms in premenopausal women and men, but not so much in the postmenopausal women because the symptoms of hyperprolactinemia are almost that of findings of postmenopausal situation, that is amenorrhea. In premenopausal women, it causes hypogonadism with symptoms that include infertility, basically because of anovulation, or oligomenorrhea due to oligo-ovulation. Amenorrhea, if there is total anovulation, 10 to 20% of them can present like that. That is mainly due to inhibition of GnRH and hence LH and perhaps FSH as well. Galactorrhea. We all correlate hyperprolactinemia with galactorrhea, but surprisingly, it is less common. It is less often. Only 24% of women will have this. Headache can be there if there is a macroadenoma or intracranial lesion. All said and done, symptoms of hypogonadism correlate with the magnitude of hyperprolactinemia. The more the levels, more will be the symptoms of hypogonadism. What are the grades? We call it overt hyperprolactinemia when it is more than 100 nanograms per ml, and this requires higher investigations. What are they? I'm going to talk a little later. You have to think of these things. Subnormal estrogen secretion and its consequences can happen, including amenorrhea, hot flashes, and vaginal dryness. Moderate hyperprolactinemia is when it is 50 to 100 nanograms per ml. It can cause either amenorrhea, if not at least oligomenorrhea. Mild elevation is when it is 20 to 50 nanograms per ml. It may cause only insufficient progesterone secretion and therefore a short luteal phase of the menstrual cycle. So you will get frequent cycles or polymenorrhea in such situations. The most important line is the last one. You can see that infertility, even in the absence of menstrual disorder, you will be wondering, her cycles are regular, which indirectly means that she has got good ovulation, yet she may be having infertility, and that is due to mild elevations of prolactin. This has to be kept in mind. Maybe there is deficiency of progesterone, maybe there is deficiency of estrogen, even at such mild elevated levels. That may be coming in the way of implantation and post-implantation survival of the embryo. Anyway, They won't know what is happening. They will present like infertility. Bone density. Women with amenorrhea secondary to hyperprolactinemia have lower spine and forearm BMD compared with normal women or women with hyperprolactinemia and normal menses. This is very important. Again, this may be something to do with hypoestrogenic state. Restoration of menses following therapy results in an increase in bone density, although it may not return to normal. So this is like cross-checking or proof of pudding. So first you associate hyperprolactinemia with low bone density. And when you treat hyperprolactinemia, you can see that restoration of the bone density, even though not up to back to normal. This is like a cause and effect relationship. Adolescents, when compared with adults with prolactinomas, have lower bone density at the time of diagnosis and less improvement after 2 years of therapy. So in adolescents, hyperprolactinemia should be viewed very seriously. Galactorrhea. As I said, most premenopausal women who have hyperprolactinemia do not have galactorrhea. Only 24% of them will have it. Many women who have galactorrhea have normal serum prolactin concentrations. That means galactorrhea is not only because of hyperprolactinemia. Even in normal levels, there can be galactorrhea and that there may be other causes. I'm going to talk about that again in the last few slides. Postmenopausal women, because they're already hypogonadal, and hyperprolactinemia does not change that situation. That's what I explained earlier. What is happening in menopause? Amenorrhea. So it's already amenorrhea there, and the symptom of hyperprolactinemia, which is amenorrhea, will not become very evident. Because postmenopausal women are also markedly hypoestrogenic, galactorrhea is rare in them. Hyperprolactinemia in these women is recognized only when lactotrope adenomas become so large as to cause headache or impaired vision, or is detected as an incidental finding in MRI, which is done for other reasons. So I hope it's very clear. In men, hyperprolactinemia also causes hypogonadotrophic hypogonadism, which is manifested again by decreased libido due to lack of testosterone, impotence or erectile dysfunction, infertility. They may have gynecomastia and very rarely galactorrhea also. These are all short-term effects. Loss of muscle mass, body hair, and osteoporosis. Even in men, there can be decreased bone mineral density. They will have body hair loss and loss of muscle mass. These are the long-term effects. So if somebody is losing muscle mass, lot of body hair, and osteopenia, osteoporosis, it is worthwhile estimating prolactin even in men. Decreased testosterone secretion and low serum testosterone are the cause of all this. Let's now look at how to diagnose. We have already done this in the sense the definition told us in men and postmenopausal women, when the value is more than 15 to 20 nanogram, the diagnosis is made. In premenopausal, when it is more than 30, you can simply say 15 multiplied by 2 is 30. Postmenopausally 15, premenopausally multiplied by 2. It can be performed at any time, since usual daily activities have little effect on prolactin secretion unless you are doing heavy exercise. Having said that, as I told earlier, sleep can actually increase the prolactin. And if you go and do very early morning fasting prolactin, it will be very high. That's exactly why we always tell, especially Manipal, we insist on this. First value may have been done at any time, but if it is elevated, we want to cross-check it. So we would like them to do it in the fasting status, but mid-morning. What is mid-morning? 8:30 to 9 a.m. So that should be done for a repeat sample or repeat estimation. I hope I'm clear. The first time you can do it at any time, unless the patient has just done heavy exercise or had a heavy protein meal, because you can't ask her to come again some other day, early morning and things like that. But if that value is higher, you usually repeat it. And when you want to repeat it, call her fasting and mid-morning, because sleep increases prolactin. What are the pitfalls in diagnosis? There is something called hook effect. Caution should be exercised in interpreting levels between 20 and 200 in the presence of macroadenoma, because it could be possibly artifactually low values due to the hook effect. Whenever there is macroadenoma, you expect very high prolactins, more than 200 actually. But if you think that the prolactin levels are very low, it is not correlating. Then you should think of this hook effect. What is that? It occurs when a very high serum prolactins, for example, 5,000 nanograms, which is possible in a macroadenoma, it saturates both the capture and signal antibodies used in the immunoradiometric and chemiluminescent assays, preventing the binding of the two in a sandwich. So the artifact can be avoided by repeating the assay using a 1:100 dilution of the serum. So that's the time you will get the correct picture. There is one more reason why there can be pitfall in diagnosis, and that is due to what is called macroprolactin. It causes hyperprolactinemia through decreased prolactin clearance. Here, you will wrongly diagnose it as hyperprolactinemia. It's native prolactin that is bound to IgG and is usually 150 to 170 kDaltons in size, compared with 23 kDalton of monomeric prolactin. So it's not of clinical significance directly, but patients can be misdiagnosed and treated as ordinary hyperprolactinemia. So misdiagnosis can be avoided by asking the lab to pre-treat the serum with polyethylene glycol to precipitate the macroprolactin before the immunoassay. So these are the two slides that you have to remember, which can cause pitfalls in the diagnosis, apart from what I said, that don't estimate in the very early morning, don't estimate after a protein diet, don't estimate after a exercise and things like that. And take history about the drugs that are being taken by the patient to have the correct interpretation of hyperprolactinemia. Now I come to the most important part, because diagnosing hyperprolactinemia does not solve our problem. The most important investigation is to know what is causing hyperprolactinemia. Because by looking at the values, anybody can, even the layman can say, because most of the reports nowadays give in the bracket the normal range. So they know that it is hyperprolactinemia. A doctor's job or a gynecologist's job is to find out what is causing it. So the evaluation is more important. And if prolactin is elevated on the second sample, that is the repeat sample also, which is done properly in the mid-morning, it is confirmed. The next step is to determine the cause. Most patients with hyperprolactinemia have lactotrope adenoma. So that has to be ruled out. Therefore, the evaluation is aimed at exclusion of pharmacologic or extra pituitary causes of hyperprolactinemia. That means whether the drugs are inducing it or whether it is due to extra pituitary causes. Neuroradiologic evaluation of hypothalamic pituitary region is very important, because I have listed right in the beginning so many causes in the hypothalamic and pituitary area. History is very important. Rule out pregnancy, because you saw in the physiological conditions that can cause hyperprolactinemia, pregnancy was in prominence. It's a non-pathological cause of hyperprolactinemia. Medications, estrogens, neuroleptics, antidepressants, antihypertensives, cimetidine, verapamil, methyl-dopa, whole lot of drugs list which I have already given to you. Headache, You have to take a history whether headache is just a migraine that she's been always having, or it's of a recent onset, which is typical of that intracranial lesion. And visual symptoms. So perimetry is very, very important. And symptoms of hypothyroidism. They are all close cousins, FSH, LH, prolactin. So if one is disturbed, other one is also disturbed. History of renal disease. That's very important because prolactin is cleared by the renal system. And if there's a renal disease, it is not cleared. And for all you know, there is nothing wrong in her cranium. There is nothing wrong anywhere. It may be just the lack of clearance from the renal system that is causing hyperprolactinemia. So we always say, in spite of so many gadgets, in spite of so many lab investigations, simple history taking will tell you so many things, provided you know the etiology. That's why traditionally in all lectures, we talk first about the definition and then the etiology and then everything, so that each one is connected to the other. Without knowing the etiology, you don't know what history to be asked. So only when you know that pregnancy can cause hyperprolactinemia will you ask history of pregnancy. If you know that hyperprotein diet will cause prolactinemia, you will ask that history. So that's how you should know everything in a particular topic. Physical examination is very important. It is directed towards testing chiasmal syndrome, that is bitemporal field loss. That's what I was talking about, perimetry. We have to send them to an ophthalmology department. Looking for chest wall injury. I told you the neurogenic chest can cause hyperprolactinemia. And signs of hypothyroidism and hypogonadism. So other evidence of hypogonadism also should be looked for in the physical examination. Lab and imaging. Test for hypothyroidism. I told you there's a close connection with all this, and renal insufficiency. Renal function test is a must in the lab investigations. MRI of the pituitary, and with contrast, if a mass lesion is found in sella turcica, secretion of other pituitary hormones should also be evaluated because they may be also affected. This is how you will differentiate from the pituitary cause of hyperprolactinemia and other causes. Because if it's a pituitary cause, in addition to hyperprolactinemia, the other hormones that are secreted are also affected. Only a pituitary adenoma can cause hypersecretion of other pituitary hormones. That's what I just now said. But any mass lesion in the area of sella can cause hyposecretion also of one or more of the pituitary hormones. This should be kept in mind. Not everything is elevated. Hormones to be assessed are, if a mass lesion is found in sella turcica, serum prolactin, of course, that is the topic of the day. Insulin-like growth factor 1, plasma ACTH, LH and FSH, who are the cousins of TSH and prolactin. Of course, there you can see TSH and free T4. MRI, normal and no obvious cause of hyperprolactinemia found, that is called idiopathic hyperprolactinemia. Maybe due to macroadenomas that are too small to be seen on imaging. So, sorry, not macroadenomas, microadenomas. So we say that MRI can diagnose 2 to 3 millimeters, but these may be smaller than that, and they are missed in even MRI, but they are giving rise to hyperprolactins. MRI in drug-induced hyperprolactinemia, only if it is more than 100 nanograms per ml, you may do it. Otherwise, the obvious cause is drugs. As most drugs do not cause an elevation more than 100 nanogram, except risperidone, which can cause an elevation up to 300 to 400. So simple in a way to explain to you, if it is less than 100, usually there is no serious cause, at least in the cranial region. If it is more than 100, whether it is due to drug or otherwise, you have to do an MRI to rule out micro and macroadenomas. There are no stimulatory or suppressive endocrine tests that distinguish between the cause of hyperprolactinemia. So we don't do that in these cases. Otherwise, usually in elevation of FSH and in progesterone, we do progesterone challenge test and things like that. There are no such tests here. One caution, hyperprolactinemia in chronic kidney disease is due to decreased clearance of prolactin. This I am probably telling the third time in my lecture. Serum concentrations can be elevated to as much as 10-fold normal, that is up to 200 in patients with end-stage kidney disease requiring dialysis. Don't go and diagnose on macroadenoma there. You know the cause is obviously here it is end-stage kidney disease. In such situations, in the absence of other pituitary hormone abnormalities or symptoms suggestive of pituitary tumor, example visual loss, typically need no further pituitary evaluation. The cause is obvious, and that is end-stage kidney disease. Hope it's very clear. Ectopic prolactin secretion from ectopic sources is uncommon, but it has been reported from several types of tumors, such as it is suspected when hyperprolactinemia is not associated with a large cellular mass and is completely resistant to cabergoline. So it's not due to macroadenoma of the brain of the pituitary area. It may be other tumors. Now I come to the last leg of my talk, that is management. If it is drug-induced hyperprolactinemia, logically discontinuation of the drug helps. You may try it for 3 days, or you can think of substitution of an alternative drug, followed by a remeasurement of serum prolactin. Discontinuation or substitution of an antipsychotic agent should not be undertaken without consulting the patient's physician. That's what I was telling right in the beginning. Before stopping an antipsychotic drug, you must see the benefits of stopping it versus the loss of or the side effects of stopping it. Patient at the most may have amenorrhea, which is okay, but stopping antipsychotic drugs may be very dangerous to that particular person. So always consult a psychiatrist before stopping that. MRI to differentiate between drug-induced hyperprolactinemia and symptomatic hyperprolactinemia due to a pituitary or hypothalamic mass may be considered. But as I said earlier, very, very rarely the drug-induced hyperprolactinemia is more than 100, but resmetirom, which is one of the antipsychotic drugs that is used, can give rise to that more than 300 or 400. No treatment is necessary in the asymptomatic patient with drug-induced hyperprolactinemia. Suppose you diagnose hyperprolactinemia more than, let's say, 30, but less than 100, and patient has no symptom, don't worry. You need not stop the drug at all. Let there be hyperprolactinemia as long as it is not harming the patient. If the drug cannot be discontinued or substituted, and the patient has hypogonadal symptoms like amenorrhea, oligomenorrhea, and things like that, or bone loss, then you may consider estrogen or testosterone therapy. I hope I'm clear. If a drug-induced hyperprolactinemia less than 100, no symptoms, don't worry, no intervention. But if the patient has symptoms of hypogonadal situation or bone loss, then you may consider estrogen and testosterone. Prolactinoma management is very important. You have to consider dopamine agonist therapy to lower prolactin levels. Also, it will decrease the tumor size and restore gonadal function for patients harboring symptomatic prolactin secreting macroadenomas or microadenomas. So dopamine will not only bring down the prolactin levels, it will also shrink the tumor. That is the advantage, dual advantage. What is used nowadays, of course, cabergoline is the #1 drug. 0.125, you always start with lower levels, 1 milligram twice weekly for 12 to 24 months, 2 years or almost, is preferred to other dopamine agonists because it has higher efficacy in normalizing prolactin levels as well as higher frequency of pituitary tumor shrinkage compared to bromocriptine. Cabergoline, with 6 months of cabergoline, that is 0.25 to 2 milligram twice weekly in macroadenoma, menses are restored in women with amenorrhea in 82%. So good. Normalization of prolactin is seen in 81%, not very much behind. Significant shrinkage of tumor is seen in 92%. Please note that. In men also, after 6 months of treatment with cabergoline 0.5 to 1 milligram twice weekly, prolactin is normalized in 86%. Nocturnal penile luminescence and sperm count and motility were restored. How do you follow up? Periodic prolactin measurement starting 1 month after therapy to guide treatment intensification. Repeat MRI in 1 year or in 3 months in patients with macroprolactinoma. Visual field examinations in patients with macrodenomas at risk of impinging the optic chiasma. Assessment and management of comorbidities, for example, sex steroid-dependent bone loss, persistent galactorrhea in the face of normalized prolactin levels, and pituitary-tropic hormone reserve. Now I come to, as promised, galactorrhea without hyperprolactinemia. Prolactin is often 46% normal in galactorrhea, even higher if menses are normal. So that means in all cases of galactorrhea, you won't see hyperprolactinemia. No cause is documented sometimes. Often it represents persistent milk secretion following resolution of a previously elevated prolactin. Suppose she was actually, let's say, lactating, and then everything comes down, but milk secretion is persisting. Galactorrhea in the absence of hyperprolactinemia is not the result of any ongoing disease. That is very, very important for us. Galactorrhea without hyperprolactinemia, the diagnosis is: be sure the breast secretion is clear or milky. Green or black fluid also usually represents milk. Bloody discharge needs proper evaluation to rule out malignancy. So the secretion, if it is bloody or blood tinged, it's a serious concern. If milk, just measure prolactin. If prolactin is elevated, cause should be sought. If it is very high, do MRI and other things, as I said. If prolactin is not elevated and no ongoing disease, no need of any further test. What is the treatment for galactorrhea without hyperprolactinemia? No treatment is needed if there is no ongoing disease. For the unusual patient whose galactorrhea causes staining of the clothes and it's a botheration to her and it's an irritation to her, then you may consider low-dose dopamine agonist, though hyperprolactinemia is not the cause, such as 0.25 milligrams of cabergoline twice a week. It will suppress anyway. It will reduce the prolactin concentration, whatever is there, to below normal and reduce or eliminate galactorrhea together. So thank you very much and bye for now. Tomorrow there is no class because tomorrow there will be a talk in KCOG, that is CPAP, continuing professional advancement program. Talk will be given by Dr. Chinmayi Datta on what next after diagnosing an anomaly. I hope that is a very important talk, and for most of the clinicians and practicing gynecologists, you may attend that. Let us meet again on Friday. Thank you and good night.